All right. So today we have Dr. Adith Mohan, who is a consultant neuropsychiatrist at the Prince of Wales Hospital, Sydney. He is a research fellow at the Centre for Healthy Brain Ageing and a senior lecturer at the School of Psychiatry for the University of New South Wales. He is also the lead investigator for a Mindgardens FND Clinic on FND. So today he's going to be talking about this pilot program. So over to you, Adith.
Fantastic. Thank you, Kate. And thanks for the opportunity to do this. I mean, I think it's a big deal, FND Awareness Day, and we want to get the word out as a collective. We're all in this together. So thank you for the opportunity to present, really. Am I able to share my screen now?
Yeah.
Okay. Let me do that. Great. I take it that's coming through. Come on, I need to. Just while it's loading, fantastic. Okay. Look, I'll get started and I'm happy to take questions along the way, Kate, anything you want to do. But again, thank you for the opportunity to present. And as you said, we were supported with a translational research grant nearly 2 years ago now to try and set up a clinical service for people with FND. The intention for us was always to try and deliver a clinic that could be considered sustainable, within the public health sector. I think we all know that it's been incredibly hard for people with FND to access care in the public health sector. So we really wanted to see if we set up a clinic using a real world model, using a minimum of resourcing, what could we do with that? And could we show that we could make a difference for people with FND if we did that? So that's what we set out to do. In this talk, what I might do is take you very quickly through a background for the way that we would want people to look at and view and understand FND. We'll talk briefly about the clinic that we're running, and I'll provide some details about how people can access information about that clinic. We'll talk about where we are now with that clinic. We're at this sort of 5 to 6 month mark since we started running. And then I will talk briefly about our efforts to bring together people that are providing services, clinical services for people with FND across the country, well, across Australia and New Zealand. And really, while we've tried to do that, and the efforts that we're making to try and coordinate services for people with FND across Australia and New Zealand. And finally, I'll finish with, there's so much that needs to be done, but what I'll finish with some of the things that we are seeing as the next steps for us specifically. I think the term FND is now widely accepted, thankfully enough, and we refer to the condition as functional neurological disorder or functional neurological symptom disorder, or FND for short, which is the clinical term that I think we would all prefer to see commonly used. What is unfortunately the case for many of our patients is they are often made to hear terms in relation to their disorder that is the exact opposite of a productive clinical term. You see people being accused of faking it or malingering it quite commonly, or feigning their symptoms. And of course, FND has lived a very long life in the science literature and in medicine, and has been known by many names over the last sort of 80 to 100 years, including hysteria and hypochondriasis. So the term that we would prefer is functional neurological disorder. Many of our patients with seizures will be diagnosed with toxogenic non-epileptic seizures. I think even that we're moving towards functional seizures being the preferred term. But this is a quote from you, Kate. But if I was to try and explain FND to someone that came in, I think this is as good as it gets in terms of having people understand that when we say somebody has a functional disorder, it is implying that there's a problem in the functioning of the nervous system and that there isn't a structural issue. It doesn't imply that the symptoms are under voluntary control. It doesn't imply that an individual is gaining access to something by having their symptoms, i.e. that it serves a function for them. It really implies that there's a problem in nervous system functioning, and I think that's important to correct straight off the bat. I think the other is that the people that we see and the people that we know have FND can present with a variety of symptoms, and that's confusing for clinicians and patients and their families alike, is that, you have people that can present with symptoms like that make it look like they might have had a stroke. You have people that present with tremors and movement disorders. I've already talked about people that may present with functional seizures that look like epileptic seizures but aren't because of epilepsy, and a whole bunch of things in between. But what's perhaps even more important to recognize, and the point that we try and make as often as we can, because it reflects the experience of our patients, is not only are they presenting with those primary symptoms, they almost always have some level of secondary symptom comorbidity, which is to say that these are things that they experience on a daily basis that disable them. Fatigue is a huge one. Almost all of the patients that we've seen in clinic have reported some level of cognitive difficulty, and anxiety and depression is hugely common as well, as are certain other things like pain and sleep issues, and an overall high level of health anxiety. It's important to recognize that FND is common. I think that this is something that we would like for our health authorities to really be paying attention to. This is just one of many studies. The reason we have this one up here is because this was run in an Australian clinic. And it's quite an old study now, and there are newer ones that have come out, but it helps to make the point that in this study, 1 in 6 people that attended a neurology outpatient clinic were diagnosed to have an FND, which is a high number. And the majority of them were younger people. And when this study followed people up at 3 months, although there are studies that have looked at people at 12 months and 10 years, the majority of people remain unwell if they're not given access to proper care. So it is a chronically disabling disorder, and it's quite demoralizing for people to be unwell for that period of time without access to help. You know, we looked at it ourselves in terms of our numbers. This is one very small audit that we did. We looked at, so video EEG is an investigation that people might have to have a confirmation of their diagnosis of functional seizures. People come in to have video EEG for different reasons. That's not the only one. But when we looked at 100 people that had come in, it was roughly about over a year or a year and a half. This is an older study now, but you know, the numbers were consistent. A quarter of those people had functional seizures. All of whom had a mean duration of illness of 3 years, implying that they had had a long road to being diagnosed, and an uncertain road after that to what help would look like. And the majority of them had psychiatric comorbidity, mainly depression and anxiety. So our, you know, local results would support what we know to be true in the literature more widely. But this is really where it gets interesting, and I think this is the bit that we are going to go to great lengths to try and get health services and government to realize. And Kate, you've been doing a lot of work with this for some years now. This is a study from the US that looked at the cost. And when I say cost, it includes, you know, emergency department visits, investigations, hospital admissions, in the lead up to being diagnosed with FND. And they estimated that cost as being 100 million pre-diagnostically. When they looked at total cost per year for people, so not just pre-diagnostic, but also after diagnosis, hospital stays, investigations, emergency, ambulance, it was close to $1 billion per year. This is obviously an American study. What is worth noting here is also that when people with FND presented to hospital, they were more likely to be admitted, and they were more likely to have higher levels of investigation, which is not just costly, it's distressing for the patient, you know, because there's uncertainty about the diagnosis. And this study estimated that early diagnosis and treatment could reduce costs substantially. I mean, you have to take that with a pinch of salt, but I'll talk about some Australian data now from colleagues of ours. The second paper on this slide was published within the last month by our colleague that I'm sure has worked with Kate many times. Alexander Lane is a neurologist in Brisbane. Professor Henry Ma is a physician in Melbourne. So this paper that they did looked at the cost of people, for people in terms of dollar value when they were being assessed and managed for functional seizures. And they estimated that cost to be nearly $27,000 per person in the period that led up to their diagnosis. What's even more interesting, I think, and that's substantial. Firstly, it's substantial, and secondly, it's important information that we didn't have before. Even though you know that to be true, you needed to see it. This paper here at the bottom was looking at the impact of just having the diagnosis explained well. That's really all it was. So Alex and his colleagues looked at about a group of people that had had the diagnosis explained either satisfactorily or unsatisfactorily. They really just divided into two groups. And what they saw is if it was done well, if it was done satisfactorily, you saw a 30% decrease in the 2 years following that relative to the 2 years before in terms of the cost that was total. And if you looked at the individual, you saw a threefold reduction in the cost for that person in those 2 years prior relative to the 2 years before. So significant improvements just from having the diagnosis explained properly. But the opposite is even more important to notice, that if it wasn't done properly, that there was more than a doubling of the cost, the total cost, and there was a fivefold increase in the individual cost if it wasn't done properly. So we have a real chance to get it right and to make a difference, not just to the lives of the individual, but really to make a difference in terms of how our health services can afford to provide care for patients. We just have to get it right. And you can, again, no argument here, that the quality of life scores and the studies that have looked at it, studies that looked at distress and disability for our patients with FND or people with FND generally, the quality of life scores tend to be lower for people with FND relative to the primary neurological disorder that it resembles. So if you look at people with functional seizures, you look at people with motor FND, and you compare them to people that have, say, epilepsy or Parkinson's disease or dystonia, that their quality of life is lower, not to mention the high rates of carer stress and burnout that we deal with in our clinics with families that are just completely distressed from not knowing what to do and where to look for help for their family members. The challenges are many. We often refer to this report that Kate and your colleagues, you authored in 2019. This was commissioned by the National Mental Health Commission, and emphasized all of the things that we've talked about already, that there are high rates of anxiety and depression, that our people with FND are presenting to emergency units across the country. But the bit that I would draw attention to also is the high rates of stigma and systemic rejection that people with FND experience on a daily basis, not just in society, but in healthcare settings, reflective almost exclusively of a lack of understanding about FND. That people do not understand FND well and do not feel equipped to understand it well. And that leads to a great level of stigma. I talked already about how our patients and people with FND are accused at times wrongly of putting their symptoms on, which couldn't be further from the truth. And the science backs that up fully, but they still hear that all the time. And high rates of disability and high rates of carer stress, which we've just talked about. And clearly there was a need for us to be working and communicating the diagnosis well, which is the paper from Alex Lane that I just talked about. But also the need for us to start setting up coordinated care provision across the healthcare landscape, inpatient, outpatient, really within GP and primary health networks, and working with emergency services, emergency departments, ambulances, ambulance care providers. So there's a need across the board. And to sort of bookend that and look at it from the other side, this was again a study by Alex Lane and his colleagues that looked at how do healthcare professionals feel about their education and training in FND? How do they feel about how well equipped they are to provide care to people with FND? And the reality is the majority didn't feel like they knew what to do. So there's a problem on both sides. There's a problem in setting up services, and there's a problem in terms of education and training. I'll talk briefly about our clinic. I talked at the very start about one of the reasons I'm here to present is because we run a clinic here now. We're based at the Prince of Wales Hospital. And I'm a neuropsychiatrist by background. I have long had an interest in FND and I've long worked with people with FND, but we were given the opportunity to really set up a clinic, but also to examine what the effectiveness of that clinic would be in terms of catering to the needs of people with FND. So there's essentially 3 components to our clinic. Everybody sees and receives. So bearing in mind, this is a clinic for people that have been diagnosed with FND by their care provider. So they've been diagnosed with FND by their neurologist, typically, and we ask that their referring specialist remain involved in their care while we're working with our patients. And it's important to do that for a number of reasons. But I think first amongst those is that we need to change the culture of care in FND, that we work with our referrers and ask them to stay involved, because it does matter. It does matter to the people that we look after, that the people that have diagnosed them are still there for them when they need them. And it creates a culture of care that's more holistic. But within the clinic, so we see people with that have been diagnosed with FND, their specialists would send them to us. They spend 2 appointments with me or my psychiatry fellow, in which time we spend a lot of time really discussing the diagnosis, what it means for them, and try and construct a narrative for our patients that makes sense to them. You know, why should you accept really that you have FND? It's so confusing to not be able to walk or not be able to talk and be told that this isn't because you have a structural issue in the brain. You know, in and of itself, that's a hard thing to accept. So there is this gap between trying to link one's symptoms between that and trying to understand the psychosocial factors that are relevant, the psychological factors that we need to work on to try and improve their condition. That's a huge gap. That's a huge jump to make for most people in terms of understanding. So we spend 2 whole appointments on that, is really just to talk about why is this the right fit for you, but also to reassure people that what they have is real and what they have is distressing and it's disabling, and you know, regardless of what they've been told in the past, we do not believe in any way that this is something that they're doing to themselves. This is a condition that they've developed and they're entitled to have good treatment for it. I have a small team of people that I work with that includes our allied health team particularly, so our psychologist, our occupational therapist and physiotherapist. Of course, we would like to have more. We discuss people with FND regularly with our neurology and rehab medicine colleagues for advice. But the core team is a very small team, and I'll talk about that. And fundamentally, we do a lot of work around patient feedback in terms of psychoeducation. I mentioned already the construction of a formulation or a narrative that makes, I like the word narrative because it sort of speaks to one's journey, which is very individual. And we've developed a whole suite of resources that we would be happy to share with people. We give people information about FND. We use resources that our colleagues have developed that are excellent. We use some of the resources that are available on FND Support Australia's website. We use resources that are available on FND Australia as well. And we've developed information sheets for people that we send to them, and we encourage them to take their time to go through it, and come back and ask us questions. So we really encourage people to have a look and then come back and say, this makes sense to me, this doesn't make sense to me, can you explain it further? And we will do that. To give you an idea of how small this team is, so you know, we have a day a week of our clinical psychologist and half a day a week of our physiotherapist and our occupational therapist, like a drop in the ocean. I contribute as much time as I can. I've put it down here as a day a week, but in reality, we all probably do more. And then we have some support from our psychiatry trainee that's attached to this clinic, but that's a variable amount of resource because that tends to come and go. This is a very crowded slide. I'll just spend a minute or two on it. This is just to give people an idea of how this clinic is running. Bear in mind that this is a clinical service for people with FND, but part of what we set out to achieve was to meet the gaps in the literature around how unwell people with FND are in Australia, at least in New South Wales. We're a New South Wales based clinic, but I'll show you in a minute how much demand there is for it. But we look at people's level of illness, we look at how depressed and anxious they are, we look at their level of physical health unwellness, and importantly, we look at their level of functional disability. And the whole point of trying to capture that is because it isn't there. And without that, we can't argue the things that we need to argue with funding bodies and government. And so we really wanted to meet that gap, which is why this is a relatively intense process of data collection through the clinic. But we see people over a period of 6 months. We see them, as I said, for the first 2 appointments a week apart. And that's really to get our heads around together what the diagnosis means. And then I see them again at 3 months and 6 months. And in that time, for some of the people that come into the clinic, we also offer a 6-week intervention if we feel that it's suitable for them, but also if they're able to attend, because not everybody's able to make the time to come for 6 weeks in a row. But if they're able to, we offer them that, and that's with our team together. Again, you know, interdisciplinary in our approach. So our team of psychologists and OT and physio, including myself, I do one of the sessions in there as well. And each of those sessions is focused on a particular aspect of FND. So what we hope to do in that 6 weeks is to build a foundation that's going to need to be built up further. When people finish with us, they go back into the community, they see their psychologist that they're seeing through Medicare, They might have access to an occupational physio. They might have access to their speech therapist. And obviously what we're doing, it's a very short amount of time. So we try and build a foundation of understanding around FND, and we cover specific things in relation to FND treatment and encourage people we provide people with a lot of material that they take home with them. And they bring that back and go through it with us. So it's a very interactive way of working with someone. Let's talk about where we're at with the clinic. So the first thing I'd point out is you can find information about our clinic on our website. We will link the website to when this talk goes online, and we'll provide Kate with the details for it. But we do have a website that's constantly being updated. I think the bits in this website that I'd point out for people is there's a section that tells referring clinicians. So if you have a neurologist or you have psychiatrists that you're seeing for your FND, then there's a section that tells them exactly how to refer and tells them who might be suitable for referral. We also have a section on resources, which we are constantly updating. So if somebody needed to be able to find links to different things about how to understand their FND, we've tried to collect them in one place for you. So you can go to the website, go to the resources section, and there'll be a bunch of links on there that otherwise you would have to Google separately to find. So these are, again, resources that colleagues have developed, including, Kate and Alex and others, but you can go there and have a look and work your way through. Where are we at the 6-month mark? The sort of point I'd make before we start talking about numbers is that, we haven't even advertised our clinic yet. We haven't told people what's out there, what we offer, because we've done that in a very limited way because of how small a service we are, also how small a team we are. And we wanted to make sure that we could meet the need for the patients that we were being sent. But even without that, we've had, 50 people referred, and we've made an effort to try and see as many of them as possible. We see people between the ages of 18 and 65. That's probably worth pointing out. We've had 32 people come through the initial assessment in that 1 week mark. And then I'll talk a little bit about the outcomes for people that have now gone through to the 3-month mark. And we've got now people finishing with us at the 6-month mark as well. So let's talk about what it looks like. None of this is going to be news to anybody that knows what FND looks like. We are just confirming what's already out there, that the majority of our patients are women. That's consistent with the FND literature. And that the majority of our people are young. They're sort of in their 30s, which is a hugely important period in one's life when you're meant to be working and studying, and not to be able to do that is just a significant diversion from what's normally achievable for us. This is just looking, and I'll draw your attention to the right-hand most column. This is looking at how many admissions to hospital people had on average over the last 2 years, how many emergency department presentations they'd had over the last 2 years. And, if I go to the next slide, that quite a substantial number of our people have had 3 or more hospital admissions in that time, 10% of them. And more than a quarter of our patients have had 3 or more emergency department presentations. It's actually more, but the way we've collected our information, if you've had 3 or more, then it just gets counted as 3 or more. But people have had multiple presentations. I mean, we know of people that have come to the emergency department here at our local hospital upwards of 20 times a year, so the numbers are significant. But what's important to note is the impact on life. What's important to note is the impact on ability to work or study. So for the people that weren't working, all of them weren't working because of their FND and the symptoms of their FND. For the people that weren't studying, half of them weren't studying because of how disabling their FND was for them. And here at the bottom, about half of those people had access to a psychologist. Less than 5% of those people were seeing an occupational therapist, and less than a quarter were seeing a physiotherapist. And we haven't captured information around speech therapy and social work, all the other important allied health disciplines as well. Just access to care is such a problem in FND. I won't stay with this too long because we've already made the point that people can present with a variety of different symptoms, which is what we're seeing, but also that they can have significant comorbidity with fatigue and pain and cognitive dysfunction, so an inability to think clearly, or their memory is off, or they can't have conversations with people because they feel so cognitively slow. To give you an idea about where our referrals are coming from, they're coming from everywhere. It's almost not doesn't make sense to sort of say they're coming from one place or another. It's coming from everywhere. And I suspect that's exactly the experience that FND support are having as well, is that there is such a lack of care and treatment available for FND that people are willing to travel great lengths to be seen, which they shouldn't have to do. They should be able to access care locally within their support networks. We've got people being referred from regional and remote areas that we aren't able to offer a service to because of how limited our resource base is. But this is something that we're advocating for. And this on the left, the table on the left is where our clinicians are from, and the table on the right is where our patients are living. So basically they're coming from everywhere. What does it look like for the patients that we've seen so far? When we say mental illness or moderate stress, that's just using language that these scales use. It's important to recognize that FND is in parts a neurological disorder and in parts a mental health issue, because it is truly a combination of both. But when we use the language that the scales and measures that we're using require us to, people would come up as having a moderate level of illness, and really rate themselves, which is this scale here, the K10, is a self-rated scale, and our patients rate themselves as having a severe mental disorder, as in the way that scale rates it. But if I come to the bottom here, these are the disability and functioning scales that we use, and people experience limitations across the board in terms of their physical health. Well, that's not surprising, but their social functioning, their ability to participate in life, their ability to get along and maintain relationships with other people, all of which are issues for the people that we're seeing. What about the people that we have seen? What about the people that have come through now and are coming through at the 3-month mark? And by the end of this year, we will have seen, between 60, somewhere between 50 and 65 people in this clinic come through. The short version is that people are doing better. And bear in mind, they're doing better with what is a very limited program of intervention. They're doing better with, we would like to be able to offer more, but in terms of, evaluating where we've gotten to, people show that this is a clinician rated scale. So people show that they go from being moderate to mildly ill at the end of 3 months. The Health of the Nation outcome scale is a popularly used overall health scale, and that shows a 50% reduction in the severity of the condition with the 3 months. These are scales that look at physical health burden on the right, and on the left, self-rated quality of health, where people can choose a health status between 0 and 100. And on that, we see people get better. So that in this case, the red bar being higher shows that they're better, that people are, whereas everywhere else it's showing that lower is better. I talked about the K10, and people show an improvement on that, and they show an improvement on depression, anxiety, and stress scales as well. So in many ways, I think the point that we're making here is that for people to be seen, for them to be acknowledged as having a significant health issue, and to be given an empathic and a multidisciplinary and an individualized treatment that speaks to what their needs are, even if it's done in a brief time frame, can still show results. There is this, we can be making a significant difference to people's lives with very little, really, and we could do better than that as well. And then finally, this is a scale that looks at functioning and disability. And again, as you see an increase, that is a good thing on this scale. So when you see the red going up, that's a good thing. And if you can see the headings down below, this is across physical functioning, being able to perform roles, and you can see that goes up quite significantly.
Yeah, that's right.
It's interesting, isn't it? It's sort of just showing that, and we talk about that a lot in clinic, that you can have a better level of functioning even if you continue to struggle with some level of symptoms.
Yeah.
There's no reason for people to accept that they can't work or live their normal lives, and so that's interesting. And they show improvements in their overall level of social functioning as well, and their general health. So it's just really interesting and important information for us to be paying attention to, I think. We also ask people what they think. What do they think of us? What do they think of this clinic that we're running? And so far, it's pleasing for us to note that almost everyone either agrees or strongly agrees that what we have provided them has been helpful. importantly, that what we provide them with, and we go to great lengths to do this, we have information sheets for carers and families. As I said already, we have information sheets and resources that we link people in with for patients, but also for clinicians. And I'll come on to that in a minute. But that helps them communicate more clearly about their FND with their care providers. And we provide them with documentation that tells their care providers, I have FND and this is what you need to do for me, because that way their care experience in the emergency department can be better. Their care experience in their GP practice when they're having a functional seizure can be better because somebody knows what to do. Everybody agreed that we had added value, which is good because that's obviously what we're setting out to do. And just overall, it was a positive experience. And these are just some testimonials from people. We have a few more, but this is just sort of, I think in particular, what stands out for us is that people feel like they've been given the tools to help themselves going forward. And that's critical in FND, because in some ways, you are looking at somebody living with a condition that stays with them for some time in some shape or form. And to feel empowered, to feel like you have control over your symptoms is a big deal. We spend a lot of time doing that. The bit that I'll add to that really is that we do the same thing for clinicians as well. So just as much as we have information and resources for our patients and their families, if they're working with a psychologist in the community who feels uncomfortable managing their FND because they don't know enough, we have extensive material to provide their psychologist. We have extensive material to provide their speech therapist and their occupational therapist and their physiotherapist, so that if they are seeing someone and that person is going, I really want to work with you, but I don't know what to do, then we will support them in doing that by providing them with material. There is often the case that I'm on the phone to a clinician in the community so that I can answer their questions about how to manage their patients with FND, and my team do that as much as possible as well. So we're often calling people, and what we really want to do is to build that up to the point where we can do that properly. I will talk briefly about the consortium, but I don't know if you wanted to do questions now, Kate, or later.
We might actually do a couple of questions now about the FND clinic. In terms of eligibility, you mentioned age being 18 to 65, and then you also mentioned you're getting referrals basically across New South Wales and regional and rural areas. Are people from sort of regional rural areas across all the different LHDs eligible to receive that 6-week service?
At the moment, not, mainly because they find it hard to attend, and we've obviously tried to blend a bit of telehealth into that, and we've had, it's a perfectly viable way of doing it, but the demand is so great that we've chosen to prioritize people that can come. For people that are referred to us from regional and remote areas, I have to say at the moment that we're not able to service those areas. You saw for yourself what staffing looks like. It's essentially 4 hours a week of staffing. But what we do again there is I get on the phone as much as I can, or my colleagues do, and we speak to those teams. There are times when we have run telehealth case conferences with the teams that are referring rather than with the person that they're looking after, so that they can be upskilled to manage, and then we make ourselves available in as much as we can for them to troubleshoot things with us. So we do what we can, but no, we're not able to see people from regional and remote areas at the moment. We would dearly like to. And a telehealth model to do that is perfectly viable. It's well established and proven to work. It's just we need more resources,
of course. And the 6-week program, is that something that is that a group program? Is it individual? So the individual with the clinician?
No, it's individual. So in fact, it's an individual with usually 2 clinicians at the same time. So that again, we really wanted to emphasize that it was interdisciplinary. So we have each person sees 2 clinicians typically at the same time. They do have sessions in there that might be with one person, usually our psychologist or with me, but the majority of sessions are actually done with 2, sometimes all 3 clinicians sitting together. So it's quite personalized in that way.
And is that done face to face, or?
Largely it is. Largely it is. Sometimes, I mean, we have had people that we've taken on from the South Coast, some of Wollongong, or we've seen a couple of people from the ACT, really because we felt like we do need to do something for this individual.
Yeah.
And so for people that are traveling a long way, we will occasionally try and do one of those sessions by telehealth to give them a break from traveling, for example. So we try and do the majority face to face because we feel like there's value in that. But
Yeah.
equally, if we had the capacity to do telehealth, we would do that as well to supplement this.
Yep. And sort of the content of the 6-week program, it looked like it was a psychobehavioral intervention. It looked like there was a lot of goal setting.
Yeah.
What might the content sort of look like that the person will cover?
So each of those sessions is taken from the literature around what works in physiotherapy, what works in occupational therapy, what works in psychology.
Yeah.
So each session is quite different. And then, as I said, there's a session there with me that goes back to the diagnosis, then allows people to ask questions now that they've done it for 4 sessions and understood their condition better. So it takes on the evidence in that regard. And the other thing it takes from is from qualitative studies, the kind that you've done, is what are people looking for in relation to their FND? Well, they want to understand it better. And so we have a session on that. We want people to be able to set goals for themselves that are driven by their values. What is important for you to achieve in the next 12 months. And so there's a session that really focuses on what people's values and goals are and how they might go about setting an occupational therapy guided plan to achieving those goals. So it's a blend of the evidence around that. It's obviously guided by what we thought we could achieve in 6 weeks. And we do provide people with a lot of material in each of those sessions. So it's sort of a workbook type approach. So people will be able to take notes as they're doing their session, and then they go home, have a look at that, and then come back to it, even after they're finished with us. When I see people at 3 months and 6 months, and they've finished the 6 weeks, we're often going through some of that material to try and revise what they could do when they have an attack. Okay, well, we're going to use these breathing techniques, or we're going to use grounding and other behavioral techniques to try and manage this attack. So it's sort of taken from all of that in a way.
Yeah, awesome. Cool. Well, thank you for that.
Not at all.
Consortium.
Okay, so the consortium, I guess we wanted to mention this here, partly to get the word out, but partly to acknowledge that regardless of how many clinics like ours there is a need for us to be working together to improve the lives of people with FND. And we recognized that early on. We knew that even before we set up the clinic. But last year we were successful in competitively applying for and being awarded a grant, a very small grant, to try and look at how we could coordinate a clinical consortium of services across Australia and New Zealand for FND. We just wanted to find out who was doing what and how are they doing it and how could we work together. And so we set about to do that. And we've called that the Clinical Alliance for Research and Education FND, or CARE FND. Broadly, as I said, we wanted to scope out what the models of care were for services that were out there currently that resembled ours in some way or that were similar to ours. Obviously, we wanted to work together to fill those gaps in data on what does it look like across the course of someone having FND in terms of the cost to them, the cost to the healthcare system more broadly, and what does it look like for them over time in Australia and New Zealand. We wanted to take advantage of the things that each of us were doing at individual sites so that we could work together to try and maximize benefit for our patients. And then we wanted to see if we could get people together and link people in. So if we were all seeing people with FND, but there was a trial running in Brisbane, for example, that somebody might benefit from, that we all had a sense of who was doing what, and that we could connect people in with research when it was appropriate to do so. So we had a number of goals. The data harmonization project that we're now engaged in is really across the clinics that we're working with to try and see if we could all agree on collecting a minimum amount of baseline data so that at the end of a year, for example, instead of 60 people, we could have data on 500 people. And that would help us really quite conclusively make the case that people with FND are in need. We should be able to say that with confidence. We do plan to lobby the Ministry of Health, and where those efforts are ongoing at the moment. We want to look at what what it looks like for people in the community. So, using MBS and PBS data, what does it look like in terms of the care providers that they're accessing outside of hospital-based clinics, which is where a lot of the work is happening. And we will be running, and it's worth saying that here, we will be running an FND symposium day for clinicians across different disciplines in November of this year. And we will send out more information about that through FND support and other organizations. But that will be in the middle of November of this year here in Sydney at the University of New South Wales. So, and we see that as one part of sort of education and training in FND. Where have we gotten to? Look, we've identified by word of mouth, really, and through contacts like Kate and others that work in this space, who's doing what. And I have to say, a glaring omission in this number is the clinic that FND Support Australia run. So that's not included in this, and it will be when we put this out. But we were able to get in touch with 15 clinics or services across Australia and New Zealand, of whom half have so far indicated an interest in pooling data for their patients, but we expect that number will be higher, and we have meetings coming to discuss that further. But here is what that looks like. These are the different clinics and services that are running across the country. This slide is from a paper that we're going to submit for publication soon, and we're now thinking about where we go from here. I guess where we're going from here is that we want to commit ourselves to providing a better outreach service to regional and remote areas. That does not necessarily look like us seeing everyone. In the healthcare literature, you will commonly see something referred to as the hub and spoke model within a step care approach. So we fit in within a pyramid of care for people with FND, but really at the bottom of that pyramid are the primary care providers, our GPs, people psychologists in the community, and how can we support them? And when it comes to regional and remote areas, we want to be working with patients, but we want to be working with teams of people that are looking after those patients within their local communities. And we can do that via telehealth, especially now after the last couple of years of COVID. I think our telehealth services are so much more mature, and people's acceptance of them is so much better. So we have a real opportunity here. We're obviously very keen to capacity build, and we do that in a number of ways, but there's the traditional model, if you will, which is webinars and the symposium that I just talked about, and engagement with and through organizations like FND Support, but also through working with clinicians, empowering them to work with patients better, providing the materials that we've spent a lot of time developing, and really, once again, leveraging telehealth modalities as much as we can. So that is me. This is my UNSW address, which is accessible. And once again, we'll acknowledge the Mindgardens Neuroscience Network for the funding that they provided, and the Sphere network for the funding around the consortium. But yes, thank you very much, and happy to take questions. I'll stop sharing.
Yep, thanks for that, Adith. Yeah, no, that's been really helpful, and helpful for people to see, what's happening in the country. What does the landscape of FND look like? Because for so long there has been so little FND. So it's great now that we're sort of getting the energy. We've got the consortium happening. We're bringing people together.
Yeah.
So,
it's interesting to see, isn't it? I mean, I think in some ways it's encouraging to see that there are so many people working in this space, and at the same time, you also recognize, I mean, that just to point out that is in no way a comprehensive listing of what's out there, but it's certainly a reasonable survey of what's out there in terms of FND services, and it's not enough. Like, we need to have more networks amongst ourselves, but also with primary care, secondary care.
Absolutely.
That is such a gap.
And so many people, will attend hospital, they're sent back to follow up with their GP. We're constantly getting inquiries from GPs, sort of going, well, I've got a patient with FND, I don't know where to refer them, I don't know what to do.
Yeah, exactly. And regardless of how many clinics we are, there's only so many people you can see in a year. And we need to be working to improve capacity in their local sector, and then really be working alongside those clinicians to support them. Anyway, it's I will say, though, working in this space, having worked in this space for 15 years now, thanks, in large part to the efforts of people like yourself, I think we're seeing a resurgence of interest and awareness.
I think it's growing.
Yeah.
Even just in the last few years, sort of like the more we do, the more need we see.
Yeah.
But there's definitely more interest now, and we're sort of struggling to keep up with the demand that's out there. But there's certainly lots of people, lots of clinicians wanting to learn more about FND and people reaching out. I feel like there's more people getting diagnosed, like maybe we're doing diagnosis better.
Yeah.
Whereas before, there was a lot of people would say, I've been dealing with these symptoms for 20 years and haven't had a diagnosis.
Yeah.
Whereas now people are getting diagnosed much earlier.
Yeah. I I completely agree. I think people are being told their diagnosis with confidence a lot earlier, which I think is a big shift, and a big shift for the better, because that is what starts people
on the right
accessing
path.
care.
Yeah.
Is if you know what you have, instead of this endless
Mm.
cycle of, we have people that have had investigations for 5 years.
Yeah.
And then that's, it's sometimes longer than that.
Yeah.
It's such a difficult
Yeah.
thing to have to go through individually, is just to have this constant cycle of investigations. But
Yeah, and not knowing what you've got is
yeah,
very
exactly.
hard. When you're sort of having investigations and they're told, oh no, your MRI is normal, there's nothing wrong with you, and it's clearly something wrong.
Yeah.
That's where it can get so frustrating and distressing for people.
Yeah, and I think that narrative is changing, as you say, the idea that there's nothing wrong. I think increasingly we're hearing people told, no, there is something wrong.
Yeah, and we know
this
there
is
is,
what it
like,
is. That's right. And it's such
yeah,
a big difference to be told that there is something, instead of being
and
told
we
there's
know,
nothing.
with the functional MRIs, like in the more recent research, we're seeing what's going on in the brains now. So we're clearly seeing, changes in connectivity in the brain and changes in function in the brain.
Yeah.
It's
absolutely.
just they're not the standard routine medical tests that are done, in hospitals and GP centres.
Yeah, and it's important to point out to people that, that those studies that have looked at what the brain connectivity looks like, it at least gives us a way to discuss with our patients and their families, that this is a real thing. This is something that you have, and you shouldn't feel embarrassed to have it because you think that it's not real. Like, it's a real condition, and there's help to be offered for it. And I should have said that when we talked about the intervention as well. We use a lot of that literature to try and shape the bits that we would focus on. So we would focus, for example, on emotional processing and emotional regulation, because we know that that's an important connected part to address. So absolutely. But it's encouraging to see where we're going. There's a lot of work to be done.
Excellent. But like you, it's sort of the resources is where it's lacking. There's willingness and passion there.
Yes.
But we're needing more resources to do the work that needs to be done.
Yeah, I agree. I think it falls to us to advocate for that. I think it falls to us to point out to funding bodies and health agencies that the difference you can make relative to the resource that's required is really huge. You can do a lot with very little. And of course, you could do more with more. But considering there's so little out there, and the fact that we're able to show improvements, with Alex Layton's paper, improvements with just the explanation of the diagnosis properly, and in our case, improvements with just 3 months of work, just shows what can be done and how much we're failing the community by not doing it.
Yeah, exactly. Yeah. Cool. All right. Well, thank you for your time today. I'm sure it's been very helpful for people to sort of hear where you're up to and what's happening.
Yeah, absolutely. Thank you for the opportunity. I really appreciate it.
Thank you.
Thanks.